session now. So, and because of that, what I'm going to do is mute everybody's mic, and then if you have a question, you can raise your hand, and I'll unmute you. Or alternatively, you could use the chat box and type in your question there and send me the question, and I'll monitor the chat box and the raised hand icon. And I very much welcome questions during the presentation and especially afterwards. So with that being said, I don't believe there's any other housekeeping topics I need to go over. So first and foremost, I want to thank everyone for attending today. This is the second of our webinars that we're offering to allow a variety of topics, to share a variety of topics with folks that are interested. Today I happen to be giving this webinar from the ACP meeting in Orlando, Florida, and so that kind of is why I'm at the restorations topic today, because it just was a little bit timely for what I'm learning about today. Okay, the first thing that I want to talk about today is a little bit about DDME and WIPMIX. Recently, DDME and WIPMIX have entered into an agreement or a partnership, if you will, and we're going to be sharing the information that DDME's been working on for about 1.5 to 2 years now, with regards to performing overnight home sleep studies in conjunction with a Bruxism or 2 Bruxism channels, and what we've learned from that activity. We've probably recorded 1,500 studies so far, and what we have found is that there are some things that we've learned, some interesting things, and we think we can make an improvement on what happens with patients that have damaged teeth. And before I get off, my slide topic a little bit, I do want to just mention a little bit about DDME specifically. So DDME and WIPMIX are kind of co-marketing this effort in offering a program that improves monitoring sleep, Bruxism being one of them. DDME has many years of experience in that area. We're 100% focused on dentists, and dentists play a critical role, in our opinion, on certain areas of patients' sleep. Obviously Bruxism's an area that's squarely in the dental wheelhouse. There are some other areas that are also in the dental wheelhouse, but they kind of venture a little bit closer to the medical field, and we'll talk about that in a bit. Let me turn my phone off. I forgot to do that. The other thing that I wanted to mention is that there's a lot of opinions, especially in bruxism and what causes it and what you can do about it. Some people are of the school of thought that there's nothing that can be done except for protecting the teeth. There's some schools of thought on what causes bruxism. There's some cool schools of thought on what you do when you see it. What's the best plan of action when you see damaged teeth? And as we entered into the area of trying to help dentists improve the management of bruxism, we decided that our motto is going to be measure and know. So rather than try to kind of accommodate the various schools of thoughts on this, we just, kind of suspend our personal opinions on what things may or may not be, and just say, take a measurement and find out for sure with your patient. So, that's been a central component in what we work and how we work with our dentists, is rather than say my opinion is this and yours is that, and kind of work that out. I'll just say, well, what did the patient do as we measure it? Okay. All right. So what's the problem? So what are we talking about? There's an image there of a couple of sets of very damaged teeth, and the idea is that when a dentist looks in and sees this kind of problem or this amount of damage, what's the best course of action to mitigate or stop the tooth destruction, and then what can be done to even prevent it, if anything. And we believe whatever is going to be done, we really do need to find out what is the problem, okay? And that requires, in our opinion, more than just observing damaged teeth, because there is some things that can be done in certain circumstances, and actually in many circumstances, when you see this type of tooth destruction. And what can be done is actually, in certain cases, we can uh, greatly reduce, or even eliminate the triggering events, the central nervous system response that is often responsible for the parafunctional activity that leads to this type of tooth destruction. And all that begins with taking a measurement and seeing what the condition of the patient is. So this has implications in almost all areas of dentistry. So one implication is if you're a prosthodontist and you're planning a rehab, and you have an apneic patient and you don't know they're apneic, wouldn't it be nice to know that the patient's going to be exerting excessive forces on your work? And wouldn't it be even greater to know that under certain circumstances, those forces could be greatly reduced or eliminated if you knew what the actual cause is. Is the bruxism its own problem, or is there something else going on that's causing the problem? And if you deal with the cause or the why, then we're actually treating the problem rather than just managing it. So again, that all starts with the measurement, and we're going to talk a little bit about the measurement here in just a second. I do want to talk about the more common, probably the most common, it may not be, but it probably is, I just don't know for sure. The airway plays a role in bruxism. I think a lot of people would agree with that statement. How you say that is you have to be careful. For someone to say that the airway causes bruxism is probably, there's a number of people that might object to that statement. And I think most people would say that there's a time association between when we can measure an airway event and then a destructive bruxism occurred. We certainly can document when that's occurring. There's been a little bit of research on this topic. There's actually probably been more research done that's going to be published, fairly, coming up. And what we're finding is that the body tends to respond to any type of arousal during sleep in a certain way. There's a pattern of arousal. And when I talk about arousal from sleep, I'm not talking about waking up and saying what's going on. What I'm specifically talking about is when a person's asleep, they're going through stages of sleep, and there's something that occurs during the sleep that interrupts the stages, and you might be in stage 3, and then you go to stage 2, and you would never perceive that, but that would occur, and as a result of that arousal or triggering event, one of the items that the body can initiate is a clench or a grind or some other parafunctional activity. So if we can eliminate the triggering event, does the clench or grind or the central nervous system response occur? And if it does occur, does it occur in the same way? Okay, so that's kind of the basic question that we're now asking ourselves. But don't be fooled. The central nervous system response to an arousal during sleep is certainly known, observed, and we see it every day in our sleep studies, and it's a real thing. Okay, so when I say that bruxism in certain cases can be prevented or eliminated, well, maybe not eliminated, it's too strong a word, but certainly greatly reduced. What I'm talking about is treating these triggering events, reducing the number of central nervous system responses. So that's kind of what I'm getting at. Just going to take a little break here, see if anybody has a question. It doesn't look like it. Okay. All right. Next thing is we're going to talk about what we have found. So there's a little bit of literature out there that says, yeah, there seems to be a correlation between sleep apnea, upper airway resistance syndrome, crescendo type snoring, and a variety of other respiratory events to clenching and grinding. But I think we could probably expand that out and say that anything, again, anything that disturbs the sleep could trigger the central nervous system response. What we have found, because we do measure the airway in a very sensitive way, so we can measure apneas and hypopneas like a lot of devices out there, but then we can also measure upper airway resistance, RERAs, respiratory effort related arousals, crescendo snoring, and when you record all these types of events on a timeline that also records the masseter EMG, we can easily see that there's a time correlation between these events and the clenching and grinding. So then, having said all that, let's just assume for the sake of this webinar that we all agree that that is true or somewhat true. What we have found is with dentists that are trained to protect the teeth with a single arch guard, and in many cases, if not most cases, that's the appropriate thing to do. But in other cases, we have found that there's reason to be concerned about issuing or prescribing a single arch occlusal guard to a patient with damaged teeth. And we have good reason to have that concern. And I'll share with you what that concern is. So what you're looking at now is 14 patients that went through a 2-night study. And these are patients that have been previously prescribed an occlusal guard before I ever met the dentist. The dentist attended a webinar, a seminar, or what have you, acquired the monitor that we're going to be talking about in a little bit, and I asked them, I said, listen, let's just do a 2-night recording on a patient that you may not have been successful as you would have liked to have been, and let's see what happened. So we did a baseline with those patients, and then we did a second night with whatever treatment that the dentist provided for the patient who had damaged teeth. And I do want to make sure everyone understands these are not sleep apnea patients. They were patients that were prescribed an occlusal guard of some sort due to the damage to their teeth or other TMD-related symptoms or problems that they had. So the interesting outcome is of the 14 patients, 10 of them, the AHI went up. So when you measure the airway on somebody with damaged teeth, you can see the numbers there on that first green column on the left. There's the list of AHIs. Most of them are well within the mild, and some of them are even well within the moderate range of OSA. And so a few were not. So it looks like there's 1, 2, 3 that didn't have any significant apnea. So 3 of the 14. The dentist was dealing with a patient with damaged teeth that also did not have apnea, okay, at a diagnostic level. The rest, the 11, had a diagnostic level of OSA. So that's a very high correlation. Damaged teeth and OSA, there's a high correlation there. So what we found, it's clear if you want to see what the dentist prescribed, you can look all the way to the right-hand column, and it'll tell what the type of splint that they used. And that wasn't actually that groundbreaking information, because there's been a pilot study that showed similar results to this, and it kind of makes sense that if you put something that reconfigures the way the mandible is associated to the maxillary, it's going to change. And when you make a change, sometimes that change in that configuration can be for the positive or the negative. Okay, so that in of itself wasn't all that interesting. What we did find that was interesting is that the amount of energy, total energy, exerted by the masseter actually went up. So we were actually able to also say that as the AHI went up, the apnea and the hypopnea index, And just if there's, just a quick, that's kind of the measure that we use to assess sleep apnea. So there's a scale there, and I think I'll talk about the scale in a little bit. But as that went up, so did the clenches and the grinds and the other parafunctional activity that we measure. So that everything increased. Now I will say, in the presence of the guard, the energy of each event was greatly reduced, but there was more events. Okay, so what we found is that even though the clenching and the grinding strength went way down in the presence of a guard, which is intended, functioned as designed, and protected the teeth. So that's all good, and that's all what we had hoped we would find with the guards. What we didn't expect and suspected but didn't really know is that because we're causing more triggering events, we're causing more bruxism. Okay, that's what it appears that's going on here. Okay, so that was interesting, and that does have implications on what we might think about doing when we look into a patient that has damaged teeth. Okay. Um, One other interesting outcome here that we found is that the snoring was the only category that actually improved for most of the patients. So there's a couple of explanations of why that might be. I don't know that we necessarily need to go through the explanations, but that's not necessarily a positive outcome. Okay, if the patient's complaint is snoring and the snoring got better with the guard for some reason, I suppose that's a positive outcome. But what the risk that has is, if you have a patient that has sleep apnea and now they're not snoring but they still have sleep apnea, then the problem is you've essentially silenced the issue. Okay, and that's not necessarily a good thing. So that was actually an unfortunate finding for us. So interesting data, and we'll talk about what that means and how we can use that data to possibly better service our patients. Okay. All right. Let's. I do want to spend a little bit of time talking about bruxism. I know we all know about it. We all see it every day. But in light of measuring it while the patient sleeps, there's some new things to take into account or consider if indeed it is you do want to record bruxism while the patient sleeps in conjunction with the airway. Bruxism is in the top 5 of most common sleep disorders. So dentists are absolutely involved in helping patients sleep better, because a lot of the damage from teeth come from nocturnal bruxism, and in not a small amount. I think it's actually number 4. There's insomnia, sleep apnea, periodic limb movements, and then bruxism. So I think bruxism is the number 4 in the top 5 categories. So that's a lot of people with damaged teeth, or putting pressure on enamel, because we can actually see kind of clenching and grinding on teeth that look pretty good. So we can actually catch it before some of the damage is occurring. I can tell you that bruxism, unless you as a dentist order a bruxism channel, the sleep labs around the world essentially ignore bruxism because it is a dental issue. It's not considered a medical issue. The Mayo Clinic put out a very good statement on this topic, and it's important enough to me that I'm going to read it to you. It says, sleep bruxism is considered a sleep-related movement disorder. People who clench or grind their teeth, brux, during sleep are more likely to have other sleep disorders such as snoring, pauses, and breathing. And what I would add to that statement is there could even be a limb movement that triggers a brux. So if a person has periodic limb movements, which is the number 3 sleep disorder, that could cause the central nervous system response and then trigger a brux. So the Mayo Clinic, who most of us respect, has put this responsibility on the dentist. And the reason that I make such a big point about this is that there's a number of people that say that dentists should not be participating in managing a medical condition. Okay, bruxism obviously is not a medical condition, but some of these other triggering events absolutely are, such as sleep apnea. Sleep apnea is 100% a medical condition. Now, as a dentist, I don't know of any dentist that say, well, I'm going to just be a dentist and diagnose sleep apnea. I've never met a dentist that wants to do that. It's just not something that I see, and I talk to a lot of dentists. However, should we preclude the dentist from assessing the airway when they're managing bruxism? Okay, that's kind of where the question comes in. And it's not necessarily that I'm looking for an answer or an opinion, but in my opinion, I will tell you, if you do want to do a good job of managing bruxism, you do have to see what is the why of it. And the number one why of why bruxism is triggered is the airway. There's other reasons why bruxism occurs, but the number one that we see is the airway. So a dentist should be participating in assessing the airway, and under no circumstances would I or anybody that I know or respect ever, imply that a dentist should manage the airway. Okay, so I am going to shift gears a little bit. I'm going to talk about the airway. And I know for many of you this is a very basic review, and you could probably do a better job of talking on this slide than I could, but just for the basis of kind of starting from the same point of reference, there's people that breathe normally, obviously. The middle image there is snoring, and we do assess snoring on a couple of access points, frequency, percent, and volume in decibels. And what's interesting about the snoring is, just from observation of so many of these studies, snoring is actually a more common trigger for a clench or a grind than a sleep apnea. And there's some theories. I've shared that observation with a number of people, and we have some ideas on why that has occurred, why I see that. But it is, it is something that we do see. And then the last picture there is a sample of an obstructive apnea, and essentially the airway closes, or in the case of a hypopnea, partially closes. So there's some flow, but not 100% flow. And in those two types of events, we also see some clenching. But what we see with the severe apneics is that the tendency over time is that the central nervous system response changes over time. And one of the things that we see is that the reaction by the autonomic system and the central nervous system seems to, the way I characterize it, is dull. It just doesn't respond the same way. So pretty soon you'll have an obstructive apnea, and the heart rate really doesn't change all that much, or the patient sleeps right through it. The clenching and the grinding just seems to go away, and it's almost like it appears to me like the central nervous system response is just kind of giving up. It just looks like it's wearing out, or what have you, and it just doesn't have the same response as to somebody that is in the earlier phases of a breathing disorder. One of the things that I'll mention real quick is that one of the concerns about assessing the airway and from the dental perspective there are a number of airway issues that could be detected by a dentist that should absolutely not be managed by a dentist. And so the DDME, we do recognize that, we respect it, and we monitor for those conditions very carefully. And when we see them, we let the dentist know, and we also train our partners to be able to identify for themselves when a patient absolutely should not be treated by a dentist for some type of airway condition. And it's actually I'll tell you, it seems like that's a negative, but that's actually, it's been our experience that that's very much a positive, and it's actually one of the more positive outcomes. And I'll explain to you why that is. So let's say that a dentist does a test and they have a condition that it's called Cheyne-Stokes respiration. So we've identified that the patient has, Cheyne-Stokes respiration is a type of central apnea, and it's a comorbid condition for a heart problem. And so clearly the dentist should not be managing that. That patient should be taken off the dental chair and actually in the case of Cheyne-Stokes, referred to a cardiologist or a pulmonologist, but it's an indication of a cardiac issue. When that occurs, one, it's great for the patient if they're unaware of that condition. So the dentist has identified that this patient's at risk for a problem and referred the patient to the appropriate medical professional to manage the problem. Okay, that is a tremendous upside. Okay, the dentist didn't diagnose Cheyne-Stokes respiration. They just saw it or it looked like Cheyne-Stokes respiration, and they referred the patient out. Now, if you're the patient and the dentist has identified that issue, and the patient gets the help they need, that's an upside for everybody. So when we talk about measuring patients, there's some concern that, okay, we're going to be measuring things that we can't do anything about. You should be right to be concerned about that, but you should also have the perspective that actually this is an opportunity for me to help the patient by referring them to the person that they need to be seen. Okay, so and I'll tell you a story that happened about 2 weeks ago now. Is we had exactly that scenario. The scenario was the patient had very severe sleep apnea. Their AHI was 72, and the severe number is 30 and higher, so they were well over double what's severe. The dentist said, I know you were hoping to get an oral appliance, and that's why we did the test, and we've learned that your disorders progressed past the point where an oral appliance is the first thing that we should try, and I'm not even going to send this to a medical professional. I'm going to just refer you to a sleep lab. And so the patient was referred to a sleep lab, ended up on CPAP. CPAP was a tremendous benefit to the patient. It literally changed their life. They had energy. They just had a very positive response to CPAP. I know CPAP gets a lot of bad press. What you don't hear is all those patients that are tremendously improved by CPAP. I think CPAP gets kind of a bad rap sometimes. And the patient came back to the dentist and said, "Thank you for changing my life. I went to the sleep lab, I got a test, I'm on CPAP. The day 2 of CPAP, I felt like I hadn't felt in years, and I want to thank you for that." So what that did is that the dentist felt good. That's obviously anybody would feel good in that scenario. The patient got the help much sooner than they probably would have had they waited, if ever, to go to a sleep lab. 2, the dentist got the credit for identifying the issue, even though they didn't treat it. Because they found it, they kind of got the credit, and now they have this very loyal patient that's going to talk to other patients about the benefits of getting the test at the dentist. So there are some benefits to taking a measurement, learning that you can't help the patient. Okay, there's some upside to that, is kind of what I want to say. Okay, so I've talked about measurements quite a bit, and I'm going to pause here and see if there's any questions. Let's see here. No, okay. So again, if you guys have any questions, just kind of click the little hand or type a chat. So let's talk about the testing. The testing, the monitor that we use is from the medical side of things. It's a home sleep monitor. It's a very, very good one. And when I say it's very good, let me explain to you what I mean by that. It measures what we're interested in. It doesn't measure the effects of what we're talking about. And what I mean by that is we actually measure the respiratory effort directly with a couple of effort belts. And you want to be able to do that, especially as a dentist, because as a dentist, you don't want to be trying to treat central apnea with an oral appliance. And if you don't know the patient has central apnea, anybody who's in the know about central apnea knows that you're barking up the wrong tree and you're not doing good for your patient. So you have to know if the patient has central apnea. So our device detects central apnea as good as a sleep lab. Okay. The surface EMG, the masseter, that's probably the thing that we bring to the table that's unique. And that because we record surface EMG in conjunction with a variety of other channels, we can kind of paint a picture of what's going on. I know historically there's been two kind of ways in which EMG gets measured. One is during the day, and the other is surface EMG, and that's the only thing that gets recorded. Okay, and although there's some valuable information in just the EMG channel, the problem is you could never know why. You just know that they're still clenching and grinding. Maybe the other benefit to the EMG only is that if they've, if it's a short-term problem and that's been resolved, then they're not clenching and grinding anymore. A surface EMG only might pick that up. But barring that, unless you know the why of a thing, it's really tough to treat it. To know the presence of it sometimes is just not enough. We do measure pressure flow. We do use a cannula for that because it's very sensitive, and the monitor that we use can actually detect upper airway resistance as opposed to frank sleep apnea. And then we have oximetry. So we have a very high quality wireless oximeter that transmits to the monitor itself. And our oximeter has a very high sampling rate, so it's accurate. And so when you record all these channels, sometimes I don't like to talk about how great it is because then people kind of get lulled into the trap that, oh, it must be difficult to use, and it's not. The other thing that's good about this particular unit is that it is very easy to use. And I will tell you that I am not a manufacturer, and so I could be selling you a variety of other devices that are out on the market. And we looked at many, if not all of them, and we found that, with the criteria that we had, this unit met the best of all the items that we wanted to measure. It was easy to use for the patient. It was easy to use for the front office. It had a tremendous amount of clinical yield. And by that I mean for the amount of effort that you put in and the cost, you get a commensurate amount of clinical benefit from that. And there are devices out there that are easier to use, but then they don't provide enough information to have a high clinical yield. There's other devices out there that collect more data. However, they're more expensive, and the patients can't manage the hookup very well. So this device seemed to have a good balance. Okay. Next slide here is I'm gonna show you a sample of raw data. Now, if you've never looked at raw data, I want you to not that you would be overwhelmed at this. I mean, it looks like, to somebody who's never looked at raw data, this is just going to look like a bunch of squiggly lines. I do want to go over this because I want you to leave the webinar with the idea that we're painting a picture. We're not just recording a channel. So the picture we're painting is the interaction between the airway and the masseter, or the EMG activity. So what we're looking at here is looks like 2 minutes of data. And those blue bars there where it says hypopnea, if you can read those are respiratory events. They're pretty obvious events. They're not subtle events by any stretch of the imagination. And here's what's going on with this particular patient. Is the patient is having a hypopnea. The hypopnea is going on. Then the patient starts to kind of mouth breathe like a fish, like we've all seen the type of sleeper where their lower jaw just kind of opens, goes up and down kind of with each breath. So that's what's happening. As this hypopnea progresses, the patient's mandible is kind of opening wider and wider, thinking that if I open my, mouth wide enough, I'll get the air that I need, and it's clearly not working. So that's one type of parafunctional EMG. So you see kind of with each breath, a little spike in the EMG channel there. And the EMG channel is the one that's kind of the second channel down, and it's black. The blue boxes underneath, those are the cannula channel. Those are where we score the hypopneas. And you can see on 2 of these hypopneas, an extraordinary event occurred. So this is where the masseter is going. We're kind of mouth breathing, and when I say mouth breathing, we're opening and closing our mouth. We're just not holding our mouth open, but the jaw's kind of going, like I talked about earlier. And then the masseter decides to go. And you can clearly see that's a different kind of event than the other mouth breathing types of events. So there's a lot going on here. And the risk is, and what I talk about all the time, is if you don't know that the airway is doing this, and this patient has damaged teeth, and you put a guard in, everything that occurs from that black line, that black channel, the masseter channel, everything below that gets worse. Okay, so if you look at this, what's going on, and you make this worse, you can see where we can actually have the opposite effect. And if we do the, change instead of an occlusal guard, get a sleep appliance or get the patient on CPAP or whatever, and imagine if we get this airway where the patient's breathing normally, will all that EMG activity go away? Well, we don't have to guess. We can just treat them, manage the airway, and then when we're done managing the airway, see what happens to the EMG. Do another test after they're done and see. And if they end up on CPAP, so be it. If they end up with some type of sleep appliance, so be it. In this case, and actually you look at a patient like this, and our physicians that we use to diagnose patients, they will take into account this type of data when they're recommending something, and what they'll take into account is, what will a CPAP do to protect the teeth? Okay, this patient's actually doing a number on the enamel in their teeth. They're damaging their teeth. And will a CPAP help that complaint or not? Perhaps, probably will get better, but CPAP obviously doesn't put anything between the enamel. So the teeth are completely unprotected, and we're kind of hoping that all this EMG activity goes away. So there is an advantage here if we go with a sleep appliance. If this patient's not too severe, the sleep appliance has the advantage over CPAP in this one area, in that the sense that at least there's something between the teeth protecting them. Okay, so that's something that I think a lot of people overlook when they're deciding what to do with their patients, is if their teeth need protecting, what is CPAP going to do to protect their teeth? Okay, so I'm going to shift gears again, and before I do that, I'm going to see, just make sure no one's okay. And a lot of dentists aren't comfortable making sleep appliances. It's just something that they don't want to do. They know somebody who is comfortable making it. They just kind of offload a recommendation for a sleep appliance to somebody or they send them to a sleep lab for treatment. So and I'm going to go back a slide real quick, see if I can do that. When you see a patient like this and they need a sleep appliance or CPAP, and if this is a non-starter, what can a dentist do to help that patient who doesn't want to make a sleep appliance? Okay, so one of the things that we came up with is, under certain circumstances, we thought, well, geez, occlusal guards can be, introduce a risk. Certainly we could say that to the airway. A sleep appliance might be overkill, or might not be something that you want to do short term. Long term, the patient may end up wanting a CPAP. So what do you do to help the patient protect their teeth without worsening the airway? So we didn't really have a product that we were really aware of that protected the teeth, was a bruxism guard, protected the teeth, and had a feature or two that helped the airway, or at least didn't make the airway worse. Okay, So what we wanted to find out is, okay, where is that product? We didn't really know of one, so we came up with it. And it's a dual arch occlusal guard. And what it is it's a pair of essentially a pair of impression trays, partial arches, not full arches, a pair of partial arch trays with an anterior hinge, much like the silencer or the tap. So if you're familiar with those two sleep appliances, if you kind of look at that middle image of the kind of silver clear appliance, you might recognize that hardware, and it's similar to a tap or a silencer, and that's made chairside. So essentially the impression trays get filled with the PVS material, you trim it up, you identify the class bite of the patient. So we're not titrating the patient to eliminate sleep apnea. We're protecting the teeth and maintaining a position for the mandible. It's a completely different indication, okay? And it's inexpensive. It's less than $100. It's made in 10 minutes, maybe a little longer if you have, to wait a while for the setting of the PVS. But the patient goes home with it. So you look at the mouth, you say, oh, geez, look, we've done a test. So we need to protect your teeth. I'm going to send you to a sleep lab because it looks like you need CPAP, but between now and then, let me protect your teeth. Or you might say, in certain circumstances, you know what, let's get you started today because we do want to protect your teeth. We want to stop the damage from occurring. Let's get this appliance in. Let's get you wearing it right away. And if you like it and it helps you, you feel better, we're going to do another quick home study, make sure that you are actually doing better, and then we can make you a permanent appliance. Okay? And the BRX Pro can be converted to a permanent appliance, or more interestingly, if the patient has sleep apnea, you can go ahead and order the appliance, the sleep appliance. Now, if you think about the implication there, the implication is you've spent a little bit of money on the transitional version. The patient has a positive response, so you know they can tolerate the therapy. You've done a test, you know they responded to the therapy. So when you go to order that sleep appliance, when you get the appliance back from the dental lab, how much easier do you think the fitting is going to go? Okay, it's almost a silly question. They're going to say, oh yeah, give me that thing, I'll put it in myself. So there's a number of reasons why we feel that appliance is beneficial. And so, some of the benefits of it, I don't want to spend too much time on this, but the benefits of it are that the patient will be used to therapy. They're not full arch or partial arch. Sometimes, dentists have brought up, well, what about the risk of super eruption or the risk of movement? And I will tell you that any appliance is going to have put pressure on the teeth, and there's going to be the risk of movement on any type of appliance. With regards to super eruption, we only wear this at night, and I'm a big advocate. I'm almost, draconian in my recommendation that the patient really just have to be diligent about the morning exercises. What do you do when you take the sleep appliance out? Okay, and the patients really have to be conscientious about doing that morning routine, and whatever that morning routine is. If you're already making appliances, you really need, I can't kind of overstate how important that morning routine is to prevent some of the side effects of appliances. The BRX Pro is adjustable. We did not use the word titratable because it is not a sleep appliance. It's made chairside in a few minutes. The purpose of the adjusting is to pick the comfortable spot for the patient for their mandible, and it's a great precursor to a permanent solution. Okay. There's a couple more images of it. There's the PVS material. You trim it up with some scissors or an X-Acto knife, and then you put it in the tray. It's really kind of a very simple design. Okay. So the thing I'm going to go over two more topics here. One is the BRX Pro does work. We have measured it. Well, I'll say it works as good as any appliance can work. There's always cases where there's going to be a non-responder. but the principles of the appliance we've tested, and the patient responded in a very favorable way, both in the case of the airway and in the reduction of the overall parafunctional activity. So what we did is we had a patient that had been treated for TMD symptoms, pain, damaged teeth, and we're completely unaware that there was an airway issue. So what we did is we did a 3-night study on this patient, a baseline with nothing, using their existing full upper arch is what I think she was using, and then we tried the BRX Pro, and we found that the AHI went from 11 baseline, and when she was wearing her guard, it went down. Actually, her AHI went down to 7.6. That's still a fair amount of sleep apnea. It's in the mild range. And then with wearing the BRX Pro, the AHI went to 3.7. Okay, so we essentially took care of the airway in this particular case. The overall energy, which is that kind of little graph in the middle of the page, the orange where it says total clench energy. I know it's kind of hard to read. So we measure the strength of clenches, and you can see what the trend is there. The baseline, the middle one, the guard did a great job of reducing the total energy, which is as designed, and then our guard did a better job. And the reason, my explanation for that particular outcome is that because we did a better job of improving the airway, there was fewer central nervous system reactions during the night. So there was just fewer events. And so the events were weak because there's something between the teeth, and then the airway was better, so there was fewer triggering events. So that's why there's an improvement from the single arch guard to our guard with regards to the total energy. Okay. I did want to mention that DDME was evaluated by clinician's report, and we did very well. It was an 18-month evaluation, and we sent them 6 monitors that they used for 18 months. It was so grueling. But at the end, we did very well, and so we've kind of had somebody objectively come in and say, yeah, you guys are doing an adequate job, and actually more than adequate. So, we're very happy with that. The reason, I talk about that a lot because one, somebody looked at what we're doing and they said, yeah, we like what you're doing. But two, I can tell you, having that group have 6 monitors for 18 months and sending that out and getting the data back and having gone through that whole process, that was a lot of work. And so I'm very proud of the outcome of that. I'm not going to go into too much of the salesmanship of what we do. I do want to kind of wrap things up, and I am going to turn the mics off. So we're going to kind of finish up. We have about 10 minutes or so that I wanted to set aside for questions. So I'm going to go ahead and I'm turning off everybody's mic right now. So if at this point, I'm going to finish up and say that how this relates to restorations is that if you're going to do a restoration work for one of your patients, and you want to, if you think about what's going on, if you kind of accept what we've talked about and you think about the implications of it, if you're going to start a restoration work on a mild to moderate sleep apneic or even a severe sleep apneic, and you don't know that they have that condition and they've destroyed their teeth as a result of the airway, and then you're going to restore their teeth, and that issue is still ongoing, think about how much more difficult your job is. Okay. Now, a lot of dentists will say, yeah, well, I put a occlusal guard in every job that I do. I said, well, we find that occlusal guards actually can worsen the problem. Sometimes they don't, sometimes they do, but you really don't know until you take a measurement. So protecting the teeth sometimes is not enough when you're going to do a restoration. So That's kind of how this ties in. So I've turned everybody's mic on. So at this point, does anybody have a question or a comment that they'd like to shoot out? No? Okay, so is that fair to say that no one, maybe I can't hear you. Does anybody have a question, or do they want to type in the chat question?
I do.
Okay, go ahead.
Do you offer classes where we can continue to study this and see hands-on and see it more in a formal lecture?
Yeah, so there's two ways in which I'm working on that. One is these webinars are meant to gauge a level of interest, and your question kind of answers that. So we are going to be putting on our own seminars, and I am working with other people who are known in dentistry to be giving seminars. And so, assuming that I gain some of the key opinion leaders' confidence, I will be speaking in conjunction with their lectures. And what we plan on doing is I will kind of promote that individual's lecture and mention that I will be playing a small part in that individual's lecture and talk about this, what we've talked about in a little bit more detail. So if you've received this invite, you will be getting updates as to when we will be doing more formal or in-depth seminars. So thank you for asking that. Any other questions?
Well, continuing on, when we do our restorative work, because now it's kind of made me gun shy about some of the cases that I have here. I guess we can test our patients when we're going to be doing some kind of restorative work. We would test them prior to doing our restorative work to make sure that they're not the type of patient that that you're looking at in the long term. We don't want to run into problems and create problems for ourselves. So I guess we can do this. I'm trying to figure out how to do this. Obviously I can see we can do this with a splint beforehand. We can put a splint in and take the monitor home, have the patient take it home, test it to see if it gets worse.
Yeah.
But restorative work, I guess we're just having to look at it and see preventatively, is this type of a patient sleep apnea type patient, which potentially can be a problem for our work.
Absolutely. So here's what a couple of the dentists that I work with in this area, and they'll do a test if there's any reason to suspect an airway problem. They'll do a quick test, and the cost to do a test is about $20, so it's not very expensive. And if they have a certain amount of apnea, they won't even consider starting the restorative work till they resolve the issue. And it could be a simple resolution, or it might be that the patient has sleep apnea, and you think, well, geez, now I just lost this big job because now my patient has sleep apnea. Well, when you look at the alternative, if you try doing a restorative job, and a lot of you that do restorations, you've had those cases where it's just warranty work, and extra, and wouldn't it be nice to be able to pick up those patients before you start the work and deal with the main issue and do the restoration? Okay, you don't, and I'm not implicating that you take on sleep apnea is what you want to do, but you certainly don't want to enter into a patient's restoration work where there's little chance that it's going to go well. So, for the purpose of reducing the warranty work or the extra work and increasing the number of patients where you identified they're at risk for not going well, I think that's a very valid test to do. Okay, so what I want to do is I believe everybody here, does everyone here have my email address? I'm going to go ahead and type it into the chat. And then I'm going to also put in my cell phone number. Okay, so everyone should, there's my email address, there's my mobile number. If you wanted to call and talk, oh geez, look, me was on mute, I'm sorry. Maria, did you try to ask a question by chance? Oh, you're self-muted. Okay. Um, by all means, shoot me an email. Sometimes it's hard to get a hold of me because I teach a lot and I have it. So email is a little bit better, but or leave a message if I don't pick up. Love to talk to you. I think the best training I get is talking to a dentist who's working with patients every day. To me, that's the best part of what I'm learning. So by all means, feel free to contact me, and if you have a question that maybe you want to ask privately or what have you, by all means, feel free to reach out. Okay. Um, so with no other questions, I'll close out with thanking you guys again for coming, spending an hour with me today. And I want have a great weekend. And again, if you have any questions, just let me know, and I'll be sending out our next invitation here in the next couple of weeks. Okay.
Thanks.
All right, guys. Thanks a lot. Have a great day.